Okay, breast reductions. Welcome everyone. This is going to be a great topic. Top 10 breast reduction questions. If you've ever considered a breast reduction, you're planning on breast reduction, or you just want to know more about breast reduction, this is the Facebook Live for you. We've got a slightly different format tonight. I'm streaming both to Facebook and YouTube, which means you can see me in stereo, but that's not the idea of it. It's just in case anyone prefers looking at it through YouTube. So we do have a lot to get through tonight. I do have the top 10 questions. I've also got some questions which have been posted already. And then I'm going to ask any questions that come up through the night. I've got a new way of doing that tonight. So if you do have a question, put it in the comments, put a Q at the start of it. I'm going to go scroll through all the comments. And anything with a Q, it'll flag it for me and I'll get to it. Then we've got, as usual, our what's coming up in June. It's a big month in June. And then a final update on the Tummy Tuck MBS survey and where that's at. So I'm excited. I hope you're excited. There's a lot to get through. I'll move my mic into place so that everyone can hear me. So we've got a few of the big names here with us tonight. Jess, Lorraine, Gab, Claudia, Kim. So I think that's enough people to get started. So without any further ado, let's get to the first question, which I think is from...
I really want to have kids, but I really want to have a breast reduction surgery. Should I wait until after I finish having a family?
Look, that's a really great question. Thanks for that one. And it's a common question, particularly in the younger patients who are considering breast reduction. I look at it from 3 points of view. So one, will you be able to breastfeed? So the numbers suggest only 60% of women can breastfeed, even without any breast surgery at all. So not everyone can breastfeed. So that's the first thing to understand and appreciate. If you have a breast reduction, the chance of you being able to breastfeed is slightly less, maybe 50%, maybe even 40%, but it's not zero. And it's not being compared to 100%. You got to compare it to 60%. So that's point one. Point two is if you have children you breastfeed, is it going to ruin everything? No. Okay. You may need some sort of revision down the track. You may not. I'd suggest if you did need a revision, probably those changes were going to happen anyway, probably more likely if you had bigger breasts and you'd be having surgery down the track anyway. I'm just checking, make sure. Yep. So yes, you may need to have a revision. It's usually minor. It's definitely not going to go back to how it was. The third thing is women having this operation are having it for a reason. They've got neck pain, back pain, grooving, shoulder pain. They can't play sport. They can't buy bras. They can't wear clothes. So imagine this. You're 25. You may be thinking about having children in the next 2 or 3 years. Maybe it takes a year or so to get pregnant. You then go through the pregnancy. So we've already added 5 years. Maybe then you have a second child. It's another 2 years. That's 7 years. And then you breastfeed. Everything has to get back. That's 8 years. So you're 25. That's if you have 2 kids. It goes out to maybe 10 years if you have 3 kids. So you're 25. You're putting it off for 35. Do you want to put off all of those symptoms for 8-10 years for the potential downside of maybe decreasing your risk, your ability to breastfeed by a small amount, and maybe needing a revision down the track? So that's the way I talk about it in my consultation. So hopefully that makes some sense. Okay, so next question.
After my surgery is complete, will I still be able to breastfeed?
Yeah, so we kind of went through that one. It is a common question, so it's worth just highlighting it. As I said, not everyone can breastfeed even without surgery. If you have surgery, so that's maybe 60%. That's what the studies would suggest. If you have breast surgery, breast reduction in particular, breast augmentation probably makes less of a difference. Breast reduction, it maybe goes down to 50%. Probably easy to assume you won't be able to, and then if you can, that's great. The reasons why you can't breastfeed, no one really knows, but potentially because of maybe some decrease in sensation. So there's the letdown reflex, as a patient of mine pointed out today. So that relies on nerve stimulation of the nipple. Also, obviously, we're removing some glandular tissue and also some ducts. And so there may not be a connection, there may not be the neural pathways to facilitate the breastfeeding. Okay, to our next question.
What is the difference between a breast reduction and a breast lift?
Yeah, that's also a great question. So this is any of you who've had a consultation with me will know this is my answer to that. Breast reduction, breast lift, it's a spectrum, okay? For me, in 99% of cases, the technique is the same and there's just a varying amount of lift, varying amount of reducing. But in all cases, there's an element of reducing, there's an element of lifting. With a lift, as nice as it may sound, you can't just shove all of that breast tissue into a smaller skin envelope and expect that it's just all going to stay up there. And let me tell you, I have tried every single technique to keep it up there. I've tucked it under the muscle, I've stitched it to the ribs, I've stitched it under the breast tissue, and it all looks great early days, and then longer term, 3 months, 6 months, 12 months, you get what's called bottoming out, and that tissue that was below that fold ends up back below the fold. Gravity is difficult to beat. So what's the difference? Not a lot. It's a question of degrees. With every reduction, there's a lift. With every lift, there's a reduction. So hopefully that explains that one. Thanks for that question.
After I have the surgery, can my breasts grow back?
Ooh, okay. Now, this is it's actually a very common question. The short answer is no, okay? So the breast tissue that we remove is gone. There's usually a combination of breast tissue and fatty tissue. And once we cut it out, it is gone. Unless you have huge fluctuations in your weight, there's not going to be a massive change in the breast volume, okay? But what I think it's a bit of a throwback, and I'm going to get into this in one of the questions in a minute. It's a bit of a throwback to an older technique, and I'm going to discuss it. Where, and I can show you on here, where we used to do a different technique, and over time, even once we have this shape, it would drop down and do what's called bottom out. Okay, and so the volume wasn't getting bigger, but there was more tissue sitting below the fold, and I think people related that to the breasts regrowing, where they actually were not doing that. So short answer is no. I think it was related to an older technique, which I don't think anyone really does anymore. I could be wrong, but the breast tissue shouldn't grow back. Now, I noticed some questions coming through. Maybe you may have just joined and you didn't hear my little announcement at the start. If you have a question, put a Q in front of it in the comments. Put it in the comments, and I'll get to it. If there is anyone watching from YouTube, I'd love for you to give me a shout out and just make sure that is working. So yeah, I will get to all your questions, but just put a Q in front of it so I don't miss anything, so I don't want to miss any questions. Okay. Been a bit of a build-up, but this is now the big one. This is the big question. Well, it's not so big for me and Kim, but it's big for some people.
difference between a lollipop scar and an anchor scar?
Oh, hang on. I didn't quite. Oh, that is, we'll get off that. A little bit of editing problems there. That was earlier. In fact, it may have even been last night. I missed that one in the pre-run through somehow. Anyway, back on track. So lollipop versus anchor. Let me do a little step back in time as to how we've got here. So I think most of you probably understand what an anchor scar is and a lollipop. So I will be drawing that in a second, but basically an anchor scar looks like an anchor, an upside down T, and a lollipop is just a circle around the areola and a straight line down the middle. Now, historically, we all used to do the anchor pattern. Now, the plastic surgery term for that is a WISE pattern, W-I-S-E, presumably named after some guy Wise who developed it. And that was associated with what's called an inferior pedicle. Now, I'm going to show you what that is in a minute. But the pedicle is what we keep the nipple alive on, the chunk of tissue that we keep the nipple alive on. And traditionally, that was based inferiorly. So it was based basically where your fold is. And so those two went hand in hand, WISE pattern, inferior pedicle. Then I think probably in the 90s, probably a little bit earlier, there was initially a French plastic surgeon, Lejour, and then a couple of Canadians actually, who then popularized a vertical scar and a superior pedicle. So those two then became joints. He had WISE inferior with all the problems I was talking about before, bottoming out and all that sort of stuff. And then you had the superior pedicle, vertical scar guys and girls. Because I think 3 of those people I mentioned actually were female plastic surgeons. And so they were the two sort of camps. And we were very much influenced in Australia in I think the mid-2000s, where the 2 of the Canadian surgeons actually came out, and they came out multiple times to conferences and presented their work. And a lot of people, a lot of plastic surgeons adopted this superior pedicle lollipop technique. I certainly used it for a couple of years. Initially, I liked it. And then I became frustrated with the long-term outcomes, which I'm going to show you in a second. But the issues are the dog ears, the bottoming out, and the low position of the nipple. And they go part and parcel with that technique. And then something kind of weird happened in the plastic surgery community in Australia, whereby somehow, all at the same time, without anyone really talking, surgeons started combining the WISE pattern, or the anchor or inverted T pattern, with a superior pedicle to keep the nipple alive. And this was kind of best of both worlds, because we got the better skin envelope shape with the anchor type incision, but we didn't have the bottoming out associated with the inferior pedicle because all the tissue was based at the top. So that's how we got here. And we all sort of started doing that, and I started doing it sort of probably 2008. And then everyone sort of starts talking, and like no one's really written this up or talked about it too much at conferences. I think Michael Moroznik has spoken of it. But we all most of us have ended up doing the same thing, and just by coincidence that merging of these 2 techniques. Of course, some people still don't do that, and they've stayed with the superior pedicle, and I'm going to explain why they may do that and why personally I don't like it, and I don't have patients particularly wanting it. All right, so here we go. This is, believe it or not, that was the short version. That was the short version of the answer. I'm now going to go into the long version. So let's hope this works. Okay, so here is a breast that I drew earlier. So these are the typical features of a large breast. We've got the breast hanging low, the fold in this patient is about here. And the upper part of the breast, you can see sort of here, that slight curve, that slight indentation. That is the upper part of the breast. Now, the nipple should sit about halfway, probably 45, 55 is what is considered aesthetically the most desired position. So if you look at sort of this height here, halfway or a bit below halfway is about there. Okay, so that is on that breast where, so based on where the fold is and the top of the breast, that's where the nipple should sit. And when you're doing a wise pattern, you can put the nipple where you want to do, and I'll explain what that means. So from there, we make a new opening for the nipple. The areola obviously gets reduced as well. We then make an incision here, and then an incision that goes in the fold. All right? And so they all come together and you get this sort of appearance. Now, before I was talking about the pedicle, and I'll just change colours here for 1 sec. Hopefully that is making sense to people. Now, what we do with the nipple, you can see this areola is quite big. We make a nice small areola. That colour's no good at all. All right, I don't like to, let's go blue, nice blue. Okay, so we cut around the areola here, and then this is what's called the pedicle. So it's this chunk of tissue where the blood supply is coming in through here, and we take this part of the skin off like that, and then this spins around into there. So if you have a look on the other side, so the left breast in this case, it's sitting in there like that, and the areola, this part here is, the pedicle is sitting under the skin. And that actually adds some volume and projection to the breast. And so that is a wise pattern anchor with a superior pedicle. Now, let me try and walk that all back. So just so that you all become expert plastic surgeons, what we used to do was, it used to be like this, and this was the pedicle, and that got pulled up, and we removed all of the breast tissue from up here. That's where the breast tissue was taken from. So all the weight was in the lower part of the breast, which is why we used to get some bottoming out. So does that make sense to anybody? I did try this on someone earlier today, but they're almost a surgeon, and they could follow it pretty easily. So hopefully everyone else has understood that. Now, this is the situation with the vertical. Okay, so because when, as I showed you before, we're doing. I just need to explain one other thing. So we're doing this, and this is the tissue that gets removed. So we're actually shortening this distance from the nipple to the fold. So we can put the nipple like in the middle of the breast because we're going to shorten that distance from the nipple to the fold. Now, one of the big limitations of the vertical technique is, okay, so they make a new opening, they then make an incision down here, but they're not shortening, okay, they're not shortening this distance, okay? So that's what we're doing with a wise pattern, because we've got this tissue, we're making an incision there, an incision here, an incision here, so we're shortening that distance. So when we were taught, so that limits how high you can put the nipple, and this is how I try and explain this to patients. Because if you leave a lot of tissue from the nipple going around into the fold, if you put the nipple too high, when you're wearing a bikini or a bra, your nipple is going to poke out the top because you need a certain amount of material to come up and cover the nipple. So if you've got your breast that's hanging down here, your bra is going to end up short. And so one of the limitations with the lollipop scar is that the nipples can sit too high if you do it like where I said, in the about halfway up the breast, or 45, 55. So they tend to put the nipples lower so that it's not poking out through the top of the bra, but then that sets your nipple too low from my aesthetic. You know, maybe that is aesthetically, some people think that looks good. Personally, I don't think it looks good. So hopefully, so the other problem, so these are what the scars look. So they get this scar here, then this is a long scar. It's going all the way down there, and you end up with a lot of gathering down here, which is a dog ear, and then a lot of times they have to come back and revise that scar, which just gives you a scar. Now, Kim and my argument against that is the least concerning scar in a breast reduction, the least obvious scar, and you'll see some photos in a second, the least obvious scar, the least concerning scar is the scar in the fold. You never see it. It's under the breast. And so it kind of is counterintuitive to avoid a scar you're not going to see and sacrifice shape. So that's what our argument is. In terms of other things people talk about, do you get breakdown there? Well, I mean, no. You can get breakdown in any wound, but again, people who are talking about that, they're relating those sorts of breakdown changes to the older technique when it was an inferior pedicle, a lot of weight there, and you did get breakdowns there. But with the modern technique of doing a wise pattern, superior pedicle, superior pedicle, you don't have the weight there, so you don't get those breakdown problems. The other thing is that we can actually set where that fold is. So I actually sutured that down to the chest wall, which is part of the internal bra technique of breast reduction, as well as the shaping techniques of the gland itself. So we can actually, to a certain degree, raise that position so that you've got a more balanced breast, which at the end of the day is what looks better. So a lot of information. We have got, there's a lot of, hopefully that makes sense. Makes sense to me. Anyway, alrighty. So let me go into some examples. Oh, no. Stuffed it. Hang on, quickly. Sorry. Okay. I think I've totally stuffed this because I did have some lollipop examples from another surgeon to point it out. But I think, can anyone just comment? Can anyone see my cursor? Can anyone just comment? Say yes, I can see it. I can see the cursor moving. Anyone at all? Okay, maybe won't. Okay, so this is a pretty typical breast reduction patient. This is what the patient said to me today. They don't want skin on skin. So everyone hates this overhang here, which is what you get with I think with a lollipop incision, because they set the nipple lower. So nope, can't see it. Okay. So that's weird. I'm pointing on the left. Okay, no cursor. Okay, I'm pointing on the left image, the one furthest away from me. So you can see from the nipple, I've covered the nipple, that distance from there back onto the chest wall, that's the skin on skin. People don't like that. It also shortens the torso, okay? So when you've got that skin in there. So I can't draw on this because this is a different technique. So I'll skip through these. You can have a look from side on. Again, you can see on the post-op, you can see actually it stands out quite well that there's no breast tissue sitting on the chest, which is what you see commonly with a lollipop incision. And this is a breast reduction. And because of that pedicle twisting back into the breast, you can see it almost looks a bit like that she's had an implant. And the scar in the fold, you can't see that. And that distance from the nipple to the fold is nice and short. Go here, front on, you see a nice cleavage. I don't know. I can't see a scar in the fold. She has got a scar running. Let me show you on me. She's got a scar running from here, right under there, under the breast. I can't see it. I just see the scars that you would otherwise see with a lollipop incision. And you can see much nicer cleavage lines. You've got much more control when you're doing a wise pattern. Now I'm not going to call it you guys are way too smart. I'm not going to call it a anchor or T, inverted T. We're going to call it a wise pattern at Re from now on because you guys are now part plastic surgeons. So another case, younger patient, and again, you can see no skin on skin, longer torso. Have a look at the left picture compared to the right. Also note our photos and compare. When we put up photos, we show the whole body. We show the lighting is as consistent as we can get it. The positions are consistent. The clothing are consistent. All of you who've been here know we are absolutely pedantic, and thank you to the amazing nurses that we have, Lauren, Sophie, and nurses before that who have really put in the effort to make sure that our photos are high quality and not showing sort of these short, inconsistent photos, bad lighting where you can't see. But again, just a very natural, youthful shape, no skin on skin, longer torso. Have a look how much longer her torso looks. And this, I want you to have a look at this one on the left and compare it to a post-op of a lollipop where you've got that bottoming out from the start, which I don't like. Maybe some people do like it. That's up to them. Maybe some surgeons think that looks great. I'm not criticizing these people. I'm just saying for Kim and I, that is not what we think looks aesthetic. Again here, like breasts are very heavy, ptotic, droopy, pendulous. That you can't see her waist because they're outside the chest. And then in the post-op, there's that extra length to her torso. She hasn't lost weight there. That's just from showing off more of her torso. Another one, even heavier breast, and just that, I can't show you, but just that nipple sitting at about the halfway point, and just a short, nice lower pole curve from the nipple down to the chest wall. And again, no skin on skin. I don't know. Can anyone see a scar in the fold? I can't see a scar in the fold. But I can tell you with a lollipop, you do get a dog ear down there, and that often needs to be reviewed. Now, the next one is not our patient. I want to be very, very clear. Kim and I, we can do the lollipop. It's not technically difficult. It's in some ways actually much simpler technique, and maybe that's why it's attractive for some surgeons. So these are not our cases. We don't do them, so I had to go to the internet to pick up some photos. I'm not in any way being critical of this person. I've highlighted my views as to why I don't think it's right. But I'm interested in your views. So make some comments if you think these look good. again, I'm not being critical, but for me, if I look at that image on the left, and this is off someone's website or social media, I'm not sure, I can't remember where we got it from, but you know, they're putting this up as their good work, and great. If you have a look at the one on the left, which is in colour, just that distance from the nipple to the fold, for my taste, is too long. I think it's too long. It doesn't look natural. It looks bottomed out before, you know, anything else has happened. If we then go to the black and white one, I'm not sure why someone would put an image up in black and white. There should be consistency, but that's a whole other issue. The nipple for me is too low. Okay, it's down somewhere near the elbow, and you know, as a guide, it should probably sit about halfway between the shoulder and the elbow. There's no upper pole fullness. It's just empty, and it's all ptotic. There's this pseudotosis, which is where the gland is hanging below the fold. If that's the look you like, I'm sure you can find people who do it. I think I've gone over why I don't like it. I think, we see people, you know, advocate for this at conferences, and I know I've been in discussions where we've tried to explain it to people, and they just, I don't know, they're very set in their ways, and they don't like to change. And I think you do need to adapt and improve yourself all the time, which is what we always do. All right.
I'm currently suffering from really bad neck and back pain. Is the surgery going to help me?
Well, this is a bit of an easier one. Great news here, and thanks for that question. Yes, this is the beauty of the breast reduction. It doesn't only give you an aesthetic breast and a nice shaped breast, and make you look better in clothes or fit clothes better, make it easy to wear bras. It gets rid of a lot of those, almost 100% neck, back, shoulder pain, grooving, all of these symptoms, rashes under the breast. So it's a very functional operation as well as being an aesthetic operation. So I think that's why Kim and I love it so much, and that's why we see so much of it. These are real symptoms that women get, and so it's a great privilege and great. It's just so pleasing to be able to do an operation that not only makes people feel better, but they also, you know, have a breast shape that they like as well. So that was a great question. All right, let's go to the next question.
In a breast reduction, do you cut off the entire nipple?
A lot of people think we do. And to be honest, sometimes we do. Okay, so it's called a free nipple graft, and there'll be plenty of you watching tonight who've had a free nipple graft. There are certain circumstances where that is a good approach and an appropriate approach, particularly in very, very large breasts, and also where the nipples are very, very, very low, and to try and keep them on the pedicle, superior pedicle, as you all know now, to keep it on that pedicle, it will cause problems with the blood supply. And just the chunk of tissue to keep it alive is too big, and you can't get an adequate breast shape. So I saw a patient today where I think I removed 2 kilos from each side, and we did a free nipple graft, and she's got a great shape, which I wouldn't have been able to do with a pedicled breast reduction. But for the majority of patients, no, it is on a superior or supramedial pedicle, which you all know what that means now. That's the chunk of tissue that is carrying the blood supply to the nipple. So it's not cut off, it is always attached. So there you go.
How long does the procedure actually take?
Okay. This is people commonly ask how long procedures take. I don't know why. I don't know. I commonly, when I ring someone, like a partner after surgery, I get the most common response is, oh, that took longer than I expected. And someone asked me the other day, what was the question they asked? Oh, that's right, I remember. Someone asked me the other day in the post-op, maybe they're watching, I'm not going to name them, but they said, were you happy? And I sort of looked at them and I was a bit perplexed, and I said, the operation doesn't finish until I'm happy. So that's how long the operation takes, until I'm happy. When I'm happy, we finish. For a breast reduction, it's between 2 and 3 hours. But you know what? If it's 4 hours because I'm not happy, it'll be 4 hours. So the operation goes until I'm happy, but on average, I'm happy after about 2.5 or 3 hours with a breast reduction. And I do try and call everyone's next of kin after. I have occasionally forgotten, but I do generally. So make sure when you're at your appointment, you notify Lauren who you want me to call, and I'll make every effort to do that.
Not gonna lie, I'm pretty scared of the recovery. What's it gonna be like?
Yeah, another common question. Breast reduction, I think, is one of the easiest recoveries of all the surgeries we do. It's largely a skin organ, so there's nothing deep, no deep sort of pain, nerves. So most of it can get covered with local anaesthetic. So I'd say most people wake up and they're pretty comfortable, minimal reliance on any of the heavy, stronger painkillers, and usually home the next day. Maybe painkillers for 24, 48 hours, and then after that, usually Panadol and Nurofen or something similar. As things progress, I'd say most people would be driving by a week, if not a week, definitely 2 weeks. And then it's just a gradual increase by 6, certainly gentle walking, no running, jumping, skipping, nothing too exertional, but usually back to everything normally by 6 weeks. Alrighty. Oh, I've got to the end. I think that's my top 10. I think that's 10. All right. So I'm now going to get into your questions. So this is a new format I've just been experimenting with, so I'm hopeful that it's going to work. So we will see. We will see. I think I did miss one. I think I didn't pull it in. So I'm going to address it without the question. I'm going to ask the question myself. Can you predict cup size? The answer to that is sort of yes and sort of no. Cup size is, this is why I struggle with this to give a good analogy. I love my analogies, as you probably all know, but it's not a scientific, cups, believe it or not, are not, this is top secret. It's not a scientific measure. So Bellini and all the other Victoria's Secrets, they're not sitting in some laboratory measuring out a C cup and making that standardized across all of their bras. I know, earth-shattering. So if you say, draw a line that is a meter, we all know what that means, okay? If you say pour out a litre of fluid, we all know what that means. A C cup or D cup or B cup can be any manner of thing. I saw a patient today who said she was a double D, and I would say she was probably an A cup. So it can be influenced not only by the bra type, also the chest diameter. So an 8C is different to a 12C. A 12C is a bigger cup. And it basically really refers to the amount of material, I think, trying to work it out. I mean, there are studies which have suggested maybe a cup is 150 cc's or grams or mils, but I'm not sure that's true. So when you're talking about can you predict the cup size, I think it's more about shape and proportionality. So as I've said, I like a nice curve. I like the nipple sitting between 45 and 55. across the height of the breast, and then a nice upper pulse slope, the nipple pointing slightly upwards. So it's all about shape. When you're talking about size, you can sort of suggest, you want to be as small as possible, or you want to maintain as much tissue as possible, or you just want to be as proportionate as possible. And within those parameters, that we can make a decision as to how much tissue that we can remove. But at the end of the day, don't focus too much on cup size. If you're happy with the shape, and it's all in proportion, and you can find a bra that fits you, and all your symptoms are gone, then that's the great aim of this operation. If you're happy with everything and it's a D and you thought you were going to be a C, you're focusing on the wrong things. It's very, very hard. And if you're ever in an operation, and some of you watching have been, when you're sitting there on the table, and one of my nieces calls a breast reduction a breast explosion, because we basically dismantle everything and then put it all back together. And when you're in that phase where everything's just dismantled, there is no way you can judge what the volume is. All you've got is really to try and get everything into proportion. But to estimate, the best way to estimate is put a finger under the bra where Bianca talks about a pen test. So you want that where that fold is. So you put 2 fingers behind there. So fingers behind there, finger in front, and everything above that, that's what we're going to keep. Everything below that, we're going to remove, other than the nipple, which goes back in. So that adds a little bit of volume to that. So that's the best way to sort of estimate how much what just breast size is going to be after. But it's largely about shape. All right, here we go. So, wow, we have had a lot of questions. So firstly, hello to everyone who's watching. Lorraine, Gab, Kylie, Jess, Kim, Kylie, Claudia, Marie, Jojo, Jessica, Mel, Elena, Bianca, of course, Britta Lee, Sarah, Samantha, Kathy. My gosh, terrific. Okay, so great question from Bianca. Do some surgeons just shove things in with a reduction without reshaping, giving it that lift? Certainly that was the old way of doing it. As you would know, like I do a lot of reshaping, internal bra, to try and to make sure the shape is stable. But perhaps not everyone does that. Mickey, good to see you. Oh, okay. Kathy, I just did my breast reduction, and that's not really a question. But I put it up there anyway. Sam, that was not wine. Whiskey, lower carbs, exactly. Oh, here we go. This is the follow-up. I love them small. I'm loving my soft one. Please tell me I don't have to go back to wearing a full-on wire bras every day. Never. No, you don't. So this no skin on skin, the other phrases people talk about are the no bra look or the French look. And so after you've had a breast reduction with me or Kim, the aim would be that you don't necessarily need to wear a bra. So you don't need to wear an underwire. That's a great question. I think a lot of our post-reduction patients don't wear any bras at all. And because we've shaped it, you maintain a nice cleavage. I did answer that. Okay, Jojo. Often have one breast larger than the other. When it will take long for the larger breast swelling to reduce. Sometimes, because you've often done a little bit more surgery on that side. But the bigger the discrepancy, the harder it is to get the symmetry. Sisters, not twins. You've heard us say that many, many times. But there could be some reasons why it would take longer, because we have had to operate more and remove more tissue. So probably more time needed on that one. Emma's got a question on volume at the top of the breast. Well, Emma, it depends. It depends how much, and we haven't gone into this. We have talked about it. I talked about it my last live. One option would be some fat grafting just in that upper pole. So that can give a little bit of extra volume in that area, a bit more fullness. If you're wanting a lot of fullness, then it's probably going to be an implant. Bianca, that's not a question. Can people with overly large breasts get perky? Yes, I think so. I thought one of the last patient I showed, not of my one, I thought they looked pretty perky. Okay. Going down. Let me know in the comments below if you like this format. It's kind of cool being able to see everyone's questions. Thanks, Michelle. Nikki, I miss Nikki. Nikki, if you don't know, was my assistant for a couple of years, and she's now working at Peter Mac and hopefully on her way to becoming a plastic surgeon. Do you lose much of cup size? Madison, it can vary. So, I mean, as I was saying before, a lot of it is often skin, particularly in cases where it's more of a lift than a reduction. So, for the girls who are very big-breasted, heavy, you are going to lose cup size. But in those ones where they're on the spectrum, they're more lift, potentially your cup size certainly can be you can be more, have better projection. I'm not sure cup size would go up, but possibly. Jess, is the nipple stitched back on or stapled back on? Stitched, I think, is most common. Currently a K cup. Wow. I'd like to be a B cup. It would be possible, but I would say for that shift, and assuming it's all breast tissue and not just skin, for that sort of shift, you might be someone who I was alluding to earlier would be a better candidate for a free nipple graft, but that's a decision we'd make in consultation. A little bit of banter between Mickey, M, and the gang. So, okay, I think that was in relation to whether you could see my cursor. No cursor. Okay. Can I draw on it? No. Pendulous. M likes my word. That's good. We might do a vote. Do you prefer lollipop or wise pattern? Okay. Near my elbow. I'm not a fan personally. All right. Okay. Oh. I don't know. Are they? Don't know. Don't know the answer to that. But if they're under, there might be some assistance with all of that. Okay. I just don't want to miss a question. So this is the reason why. Here we go. Having tummy down breast reduction or having them separately, is there any? No. So they're independent procedures. We can do them together. Mummy makeover commonly. I think there's been a big increase in requests to do those procedures together, but they can be done apart. And there's obviously benefits in doing them together. One recovery period, one anaesthetic, one time off work, but certainly they can be done separately as well. Is liposuction included? Yes, generally yes. It's a common thing. I think it's something that's commonly overlooked by some surgeons, not us. But that fold over here that folds over your bra strap, it's important to address that. Sometimes liposuction is enough. Sometimes we need to extend that inframammary fold incision to remove some extra skin from that area. Bianca, I don't know, it's not a secret, but Bianca's actually trained to become a nurse, which we're very excited about. Tony Bones, great question. I'm going to go to our website in a second, and I'll show you how you can do it from there. But you can ring us, you can text us, you can email us, you can direct message us, you can Facebook message us, you can, I don't know, smoke signals, whatever, however you want. Does it? Yeah, usually yes. Mostly yes. Certainly they get less shallow, but mostly they go. Emma, is it true the clinic's called plastic surgery cannot be? If a clinic is called plastic surgery, you cannot be covered by Medicare. No, I don't think that's true. I don't, if I've understood that correctly. It's covered by Medicare if there's a Medicare item number. 45523 is the number for breast reduction. Sam, I said put a Q. Can ordinary bra surgery make your breast drop? I don't think so. As I said, internal bra, it's all pretty stable. Forever. Oh my gosh, so many questions. What happens to little hairs? What? I'm not sure what hairs. If they're in the skin we've cut out, then they're gone. Around the nipple, we're making the areola much smaller, so maybe they would go from there. And is there a time post-surgery that you decide to do lipo to the breast or anywhere else? I'm not quite sure. When having a breast aug and lift, will the areola on both breasts be the same shape, or does it vary? Should be the same shape. Do you mean if for one person having a breast aug and one having a lift? With a breast augmentation, we don't generally touch the areola. It's usually a bad thing. Some people sort of do these periareolar things which stretch out and they look horrible. But if you're having them a breast lift, we do change the areola. Okay, wow, that seemed to be a popular way to do questions. Do you expect my apology? I don't think you've got anything to apologise for. I missed that. Anyway, okay, so that is we are getting to the end. June. There are 5 Wednesdays in June, which is just exhausting for us. Obviously tonight and we'll see if I've done my GIF at the right speed. I've done breast reductions. We've got a podcast next week. There's a Facebook Live on Mummy Makeovers with Kim. I needed to make this 5 seconds. I'm going to get to it in just 1 second. Then we're doing some Instagram Q&As and then another podcast, The Hard Questions. Our photo comp this month is for you to send us photos of you doing workouts during the cold winter months. It is much harder to exercise. It's harder to get up, but it's important, and you should all still keep exercising. Okay, so if you want to know more about I go over this every time. We've got our Instagram page, and someone asking earlier, how do you find out more? How do you start the process? Go to our Instagram page. A lot of information there. You can message us from there. We will get it. There's also Mediskin. If you're on the page, Instagram page, join the Mediskin page. They're different. It is really starting to take shape. We're getting lots of great content. We've got a new menu out. There's a great Instagram story there today introducing all the staff who are involved. Please go and look at that and follow us, comment. It's a great community that you can meet lots of people there as well. And there's no better place than the Girls group. And I expect everyone who's on here tonight to already be on it. If you're not, please join. If you know someone interested in plastic surgery, tell them to join. It's a great community. There's a lot of information there. We're up to 1.7 thousand followers, which is just great. We're very excited about that. And now our website also. So our website, we do keep our website very up to date. Someone asked before, how do you start the process? Down in this bottom corner, you can see our our little widget there. I'm not going to put that in. You can send us a message through there. We've got our photos. You can pick different procedures, and then they'll come up in the screen below, and then you can scroll through and pick whatever you want. We've got pull-down menus. You can meet all of us. We've got our breast menu. You can go into there. All of our prices are there. You won't see other practices who do that, but we do it. And again, you can start a chat from within there or inquiry. There's some information about the surgery all in there. We've got our rewards program. So if you join our rewards program, there are benefits in terms of Mediskin. All of our social media is in there. Mediskin is in there. We keep it up to date. A lot of practices now ignore their websites. We don't. And a special plug to our YouTube page. I really want to get this going. I think I'm on the intro here.
Hi, I'm Richard
Can't
Blunt
hear
from
it. Anyway,
Plastic
doesn't
Surgery
matter.
in Melbourne, Australia. You're watching one of our videos where we give you an inside view
Might
of
be
the
on.
exciting world of
There we
plastic
go.
surgery.
I think that's playing.
If you do have any burning questions for us and you want us to answer them,
Let me just-
please leave a comment at the end of the video down
So
below.
that's me
or
talking there.
directly
But we've got
via one of our
lots of
social media
videos. All our Facebook
Today, I'm
lives
going
are
to talk
there.
about excellence in plastic surgery.
There are playlists.
Simplistically,
You
most
can
people
go into the
think that
playlists. We've got breast reduction playlists, Facebook Live playlists, tummy tuck playlists, FAQ playlists. We've only got 109. All right. I am back live. I think I went over an hour. I think that's why. So I don't know if anyone's out there, if you're still back in there, put a message up if anyone can see. I don't have much to go. You're back. I'm back. I'll give it 1 minute. We're back on. I can't see how many people are on. Would you believe it? I went over an hour. Naughty me. It's a shame because I wanted to get into this one, which has been a little bit interesting during the week. So
you can't then dress yourself. As I was saying, sometimes my partners have to put my underwear on. That is so embarrassing. I feel it was huge. Not being able, as I said, to dress the kids, not being able to take them out to the park. When I had my second child, I couldn't hold him, I couldn't breastfeed him because of the weight on your spine is going to be too great. There were so many things.
Alrighty, so that was Tina. That was an amazing podcast. As many of you will know, we were very, very active in the campaign to bring back the Medicare item number for tummy tucks. So we've just found out today that 1,400 surveys were filled in, 1,200 from patients, which is very exciting. Sadly, only 24 from ASPS members. 2 of them were me and Kim, so only 22 others. And we had 2,500 clicks on the link that we created to the survey. So we're really, really proud of the effort and the work that we put in to contribute to this really important women's health initiative. So we're super grateful to all of you who contributed, and we hope as many of you as possible did get to fill out the survey, but also to all the plastic surgeons who did support us and reposted our social media. So while it was disappointing that a local plastic surgery practice chose to use this as an opportunity to complain about us, we certainly felt justified in supporting this very important women's health advocacy work. Finally, Kim and I have officially reached out to ASPS to help modernise the guidelines with regards to advertising, so that we can continue to educate and inform you, our patients, which we think is just important in giving you access to the best information to make the best decisions. So we look forward to hearing from ASPs as well as working with them to bring the guidelines back into the 21st century and utilise all the wonderful tools that we have available to us to communicate directly with all of you. So that has been a massive live. I broke all protocols by going over an hour, but many of you have stayed on, which is many of you have stayed on. Please go back, listen to Tina's podcast, listen to all of our podcasts. We've just done another 2. I think we're up to maybe 36, 37. So in these cold winter months, when you're going for a walk, pop on our podcast, like it, comment. If you have any ideas for podcasts coming up, please let us know. So that's it for me. It's going to be a big month. Look after yourselves. Stay safe. Thanks for watching.